Now we come to the most dangerous complication of pneumothorax. That is the tension pneumothorax. Why we call it tension pneumothorax? Because when doctor sees such patient, doctor develops tension or what?
No.
Doctor does not develop tension. Okay. Nurse develop tension. Why we call it tension pneumothorax?
Patient is in stress.
Patient is in stress. Rather, I must say patient is in distress.
Distress. Doctor. So sometimes.
And doctor should also become distressed to manage this. Remember one thing. Tension pneumothorax is a type of pneumothorax in which air in the pleura is under tension. Trapped air is under tension, under high pressure. And if you suspect, now I will ask a question to one person. If you suspect that there is a person, the patient has come to you and patient has a history of sudden chest pain, and after that patient developed dyspnea, right? And when you examine the chest, you suspect, I will tell you what are the findings in chest later, you suspect that there is tension pneumothorax. My question is, with this young man, that which investigation you will order first of all? Yes, please. Pneumothorax can be detected on chest X-ray, can be detected by ultrasound, and with very big detail, it can be detected by CT scan. My question is, I really want to hammer this in your mind, this question, and its right answer, that if a person comes with chest pain and severe dyspnea, and you find you have some findings in the chest, which I will tell you later, and you suspect that there is tension pneumothorax, you should immediately refer the patient for X-ray, chest X-ray, or ultrasound, or CT scan, or what should you do? CT scan. Remember, you may receive the dead body back.
This is very emergency condition.
It's a very emergency condition. This is what I want to hammer in your mind, right? In your cerebral cortex, even into your cerebral cortex. That once you suspect tension pneumothorax, I have not explained what exactly it is, but I'm telling you, once you suspect what? Tension pneumothorax, you should be under tension. You should not send the patient for any investigation. Every minute counts. The immediate step which a good doctor or a healthcare provider will do, that is decompress the chest immediately. Immediately find some wide bore needle and push it through second intercostal space in mid-clavicular line on the suspected side of pneumothorax. Stick the needle, and if lot of air come out, diagnosis is confirmed. And it's not only about diagnosis. When air will come out, pressure on the lungs will be reduced. And that may be life-saving. I will explain. Because if tension pneumothorax is not rapidly managed, it will end up into ventilatory failure, severe hypoxemia, and also cardiovascular collapse. I will tell you the mechanism. But first you remember one thing, that when we say there is tension pneumothorax, healthcare provider, as soon as he suspects there is tension pneumothorax, healthcare provider should be himself or herself under tension, right? Not sending the patient for any investigations, because it will waste very, very important time. You are understanding? Next time in your life, it means you should know how to clinically diagnose tension pneumothorax. To make a diagnosis of tension pneumothorax, you are not supposed to depend on the labs, investigation. A very good doctor, even very good nurse, rather every nurse and every doctor, every medical health care provider should be able to suspect and make a reasonable suspicion of tension pneumothorax. Is that right? Now what's wrong in the tension pneumothorax? I told you in closed pneumothorax, once the air has escaped here, it is no way. Right? The point through which the air escaped, that has been closed. In open pneumothorax, there was two-way air passage. Right? That air will enter into pleural cavity during inspiration and escape during expiration. Do you think here, because air has an escape way, whatever enters, some of it also escape, So here the air is not developing tension. Let me tell you how the air may develop tension in the chest. Look here. This is your beautiful heart, right? And here is your cable system. Superior vena cava coming from here and inferior vena coming from here. Now you imagine what has happened here. It's a very bad situation, very, very bad looking. Okay, let me draw it again more clearly. What happens in tension pneumothorax? First of all, I must draw the right heart. This is the left heart, right? This is supposed normal first of all. I'm developing making the normal lungs. And of course here is the pleural. What is this? Visceral pleura and parietal pleura, and same here. Visceral and parietal pleura, right? Here is of course your respiratory passage is also coming and going to both sides. Now, and here is your chest wall. Let's suppose I make it chest wall. Now please focus on this diagram. What really happens? Let's suppose there is stab wound here. There is stab wound here. Okay, I'll make it more oblique, right? And this is the point of entry. Now, just imagine that once, let me correct it a little bit. Let's suppose air is coming from chest wall, right? This is your, which pleura? Visceral. And what is this pleura? Parietal. Now you imagine, this is our entry point. When person is doing inspiration, from here the air is sucked in. From the entry point during inspiration, air goes in, right? It is entering in during inspiration. But during expiration, this flap is compressed against the other part. When this is compressed again, air cannot escape. During inspiration, air enters. But during expiration, this flap seals the exit point.
One-way valve.
So it converts into one-way valve. It's not two-way anymore. With every inspiration, it will take the air in. With every inspiration, a little air will come in. But during expiration, it automatically seals and air cannot go out. So what happened? With every respiratory cycle, air will progressively enter into this. When air will enter, it will lead to collapse of the lung. It will lead to collapse of the lung. And with the time, there may be so much air that, first of all, now what is happening? With every inspiration, air is coming in. During expiration, it cannot go out. Within inspiration, more air come in. During expiration, this closes and it cannot go out. So in a way, pleural cavity convert into an air trapper. It sucks the air in but does not release it out. So with the time, pressure here will become more and more positive. And when more and more intrapleural pressure will become positive, this will push the lungs. Of course, when Normally when air enter here, both layers of the pleura are separated, and due to lungs natural recoil, lungs become collapsed. But in this case, story is more than that. Not only due to their natural recoil, lung become collapsed, but because air is progressively accumulating into pleural cavity and developing very positive pressure. Really speaking, air in pleural cavity is under tension. Of course, if you enter somewhere and you are not allowed to escape, what do you think? You will be under tension or you will be happy? You will be under tension. You enter somewhere and you are not allowed to exit. You will be under tension. Same thing happens when more and more air during every inspiration come out but cannot go out. Come in and cannot go out. Remember, this air can come from lung side through visceral puncture, visceral pleural puncture, or may come from parietal. But once such a valve mechanism develops at the point of entry, that with inspiration air comes in, during expiration flap closes. This is one way. This is one-way valve. Here, progressive accumulation of air into pleural cavity, there is a big pneumothorax and it is under high pressure. So it will push the structures with pressure. Not only affected side of the lung, even that lung is pushed on the other side. Even that pressure may compress and may lead to compression of cable system, even kinking of the cable system. You mean that due to all this thing, distortion will develop here. And what could be the distortion? That superior vena cava may become like this, inferior vena cava come like this, and this was the lung here which is under pressure. You are understanding? I must say it is something like this, very dangerous situation. This is called tension pneumothorax. What is tension pneumothorax? Tension pneumothorax is a type of pneumothorax in which intrapleural pressure remains positive throughout the respiratory cycle. During inspiration or expiration, pressure here is positive. Why tension pneumothorax develop? It occurs in those situations where the point of entry of air into pleural cavity act as one-way valve. During inspiration, air escape, but during expiration it cannot exit. During inspiration, air enters into pleural cavity. During expiration, it cannot go out. Due to this reason, there is progressive accumulation of air, and this air develops pressure more above the atmospheric pressure. Is that right? This will forcefully compress the lung, and this compressed lung even will be pushed to the opposite side, and that may compress the mediastinum and lead to mediastinal shift to opposite side, and even opposite lung may be also partially collapsed. So very dangerous, life-threatening situation, right? Because it can lead to two problems: collapse of the respiratory system and collapse of the vascular system, cardiovascular system. Cardiorespiratory collapse will occur. Why? Because when there's too much pressure on the lungs, can it do its ventilatory functions? No. Even other lung may be partly compressed also. So first of all, what will happen? That ventilatory failure leads to severe hypoxemia. It will lead to severe hypoxemia. Second problem will occur that when mediastinal shifting is occurring, there is kinking. Kinking means bend. Kinking and compression of mediastinal structure, especially cable system. If it is compressed and bent, can venous return come here? No. So what will happen? That venous return to the heart dramatically decreases, right? And naturally, if there's no blood coming to the heart, what will happen to cardiac output? Decrease. So what happened? Cardiovascular system collapses, right? And of course, when mediastinal shift is there, even trachea is also shifted. You are understanding it? Now in this person, the immediate step should be, the moment you suspect, your patient is having dyspnea probably due to pneumothorax. What kind of pneumothorax? Tension pneumothorax. You should immediately do the decompression. Now, question is that in such patients we don't have time for investigation, and we have to diagnose the patient clinically. Now, how we diagnose it clinically? I will tell you about the clinical features. And first of all, before that, let few causes again. Remember, any type of pneumothorax can convert into tension pneumothorax. It means tension pneumothorax is really a complication of pneumothorax. It's a really very dangerous complication of pneumothorax, because pneumothorax is simply air or gas in the pleural cavity. But if this air or gas become under high pressure, then it is tension pneumothorax. So how would you diagnose this patient? Let's do methodically, step by step, right? Before I go for clinical feature, again a brief review. Once the air escape and entry point closes, what is this kind of pneumothorax? Closed pneumothorax. Entry point during inspiration and expiration in both part of the respiratory cycle remains open. What is this kind of pneumothorax? Open pneumothorax. And if entry point allows the air to enter with every inspiration but doesn't allow the air to escape out during expiration, what is this kind of pneumothorax? Tension pneumothorax. Any kind of pneumothorax can convert into tension type of pneumothorax, but especially you should think of some causes, especially in your mind. CPR sometimes end up into tension pneumothorax. Positive pressure, mechanical ventilation. Positive pressure, mechanical ventilation. Then trauma, chest trauma, and then any other cause, but at least these three should be in your mind. That is, suddenly patient develops severe dyspnea and other features of tension pneumothorax, and patient is on, what is this? Positive pressure ventilation, or you were doing CPR and still patient is not getting better, right? Or there has been history of trauma, and after that trauma may be non-iatrogenic or iatrogenic. So, and after that patient develop the classical features of tension pneumothorax, immediate intervention, right? It's medical emergency. Now, what are the clinical features? Listen, this patient is undergoing a major problem, right? Breathing is difficult, severe problem in breathing. With that, in severe cases, there is also cardiovascular system is collapsing. Is that right? So when you look at the patient looks very distressed, anxious. In very advanced cases, maybe even cyanotic. And sympathetic overflow, diaphoresis, sweating. You see a patient which is having tachypnea. Rather, I must use the word patient under respiratory distress, because you will find that patient is fighting for the breathing with the help of accessory muscles of respiration. Patient is activating all his accessory muscles of respiration, right? So patient is under, when you look at the patient looks under respiratory distress, anxious, initially pale due to sympathetic overflow, and then in advanced cases eventually cyanotic, severe hypoxemia, and with that sweating, diaphoresis, right? You immediately check the vitals, pulse. It will be weak or strong?
Weak.
It will be weak. Cardiac output is dropping, but rapid pulse, right? Weak, rapid, weak, thready, because rapid and weak, thready pulse. You check the blood pressure, it is progressively falling. Is that right? Then you look on the neck. Neck veins will be distended. Gorgeous? Engorgement. Oh my God. Sure. I thought he is saying neck veins will be gorgeous. No. They will be engorged. Right? Don't see these things in this situation. Save the patient first. Okay? So again, patient under high stress, rather respiratory distress, pale, cyanotic, sweating, it means there is something seriously wrong, right? It may be some cardiorespiratory issue. Pulse is going up and blood pressure is going down. Is that right? Respiratory rate is high. we say tachypnea. But then we come to those, you have to examine the chest to make more clear diagnosis. Now what you will find on the chest, first of all, that side, for example, I'm the patient with tension pneumothorax, and let's suppose tension pneumothorax is on the right side of the cavity, right? Pleural cavity. Now what will happen? Not only lung will go in, even chest wall will bulge out. Is that right? So chest wall will bulge out, and movement of the chest wall on the affected side will be less, reduced. So it means hemithorax will be bulging out, and movement of the chest wall will be reduced on the affected side. If you palpate the trachea, what will happen to trachea? It may be deviated to other side. It may be deviated to the opposite side of the pneumothorax. And after that, if you do percussion, this area where there's a lot of air, this will be hyper-resonant. It will be hyper-resonant. Even this air trapping area may enlarge so much that area of cardiac dullness is pushed on the other side, and in right sided tension pneumothorax, even diaphragm and liver are pushed down, right? But up to now, what were the most important sign here? Deviation of the trachea. Deviation of the trachea, shift, mediastinal shift, which can be, so patient dyspneic, under distress, right? Pulse going up but weak, blood pressure going down. Immediately check, first of all, what is this? Trachea, is it central or not? If it is deviated on other side, immediately do what? Percussion. That side will be hyper resonant. If it is hyper resonant, what is the next step? Immediately put your stethoscope. Absent breath sounds here. Absent breath sounds here. Now you are really making clinical diagnosis. That on one side of the chest wall is bulging, chest wall movement are less, trachea is shifted to the opposite side, chest wall is bulging, movement of chest wall on the affected side is less, trachea is deviated on the other side, neck veins are gorgeous again, engorged, because veins cannot drain into cable system. Engorged. Is that right?
No bad sound.
Immediately you percuss, hyper-resonant note, right? You auscultate. On the affected side, absent breath sounds. Forget about everything. Immediately go for wide bore needle, right? Wide bore needle and second intercostal space, mid-clavicular line on the affected side. Push the needle in. If your diagnosis was right, clinical diagnosis was right, the moment you push the needle in, air will be come out hissing under pressure. Diagnosis is confirmed. Then what you do with the needle? Once you get the air out, you immediately
Remove it.
not remove it. Not immediately remove it. Keep the needle there. Right? In most of the cases, until you are not sure of the underlying cause of what caused this medical emergency, you stick the needle there and don't remove it. Actually, what you have done, you have converted the tension pneumothorax into open pneumothorax. You have converted the tension pneumothorax into open pneumothorax. Then you can take a sigh of relief, and your patient may be breathing also well. And then you arrange for thoracostomy tube. Chest tube, right? You need to put a chest tube so that if air, even if again traps, there's a way to get it out. You put a chest tube, and after that you remove the needle. After that you remove the needle. So it's very important that in case of tension pneumothorax, you should be under tension. You don't have time for investigations. First save the patient, then think of investigations and what really happened to the patient. Simple. Distressed patient, sweating, right? Tachycardia, tachypnea, hypotension, engorged veins, deviated trachea. affected side hyperresonant and absent breath sounds. Rush for wide bore needle and stick it into second intercostal space, mid-clavicle line on the affected side. So decompress. So lungs re-expands. Is that right? After that, of course, you can, if you want, you can do all the investigations you like. You can do the chest X-ray, you can do ultrasound, even for underlying causes, especially when there is a secondary cavitary lesion. You would love to do CT scan. Is that right? Further investigations in detail will depend on what is the underlying what might be the underlying cause. Is that right? Any question up to this? Anything you would love to discuss? Yes.
What is the role of oxygen?
Yes, what is the role of oxygen? Again, this person is also put on high level of high concentration oxygen. I mentioned it previously. In any kind of pneumothorax, when you put high flow oxygen, that helps for the air in the pleural cavity, it helps it to increase its oxygen concentration, right? So that it can be better absorbed, right, than the nitrogen containing air. Is that right? Any more questions you have? Yes.
Sir, while doing CPR, if there is tension pneumothorax, patient is already unconscious, he may be dyspneic. So how we will come to know that there is tension pneumothorax?
Yeah, during CPR, it is not necessary that during the CPR you know that there is pneumothorax. If patient revives and then you find still there is difficulty in breathing, immediately put your stethoscope, check the trachea, and if you suspect it, forget about CPR, first put the needle. Right? Yes, you have a question.
In open pneumothorax, the pulmonary cavity is communicating with the outside.
Okay, open pneumothorax, pulmonary cavity, pleural cavity may be communicating through the parietal pleura outside, or in other patients it may be communicating with pulmonary airways through the visceral pleura. Remember, any kind of pneumothorax, either it is having due to puncture of parietal pleura or puncture of visceral pleura. For example, tension pneumothorax, if it develops from the trauma, for example, stab wound, then of course air from outside is going in. But if tension pneumothorax occur after some cavitary lesion, as I explained in previous video, cavitary lesion melts away, a bronchopulmonary fistula form, right, and flap is there, and air enters into pleural cavity and cannot go back. In that case, air is coming from the lungs. So some patients of tension pneumothorax are getting the air through the chest wall, and other patients of tension pneumothorax might be getting air from the puncture of lung. The real mechanism is that trauma can lead to closed pneumothorax. For example, simple stab wound can lead to closed pneumothorax, can lead to open pneumothorax, even can lead to tension pneumothorax. Is that right? If there's stab wound and air is sucked in during inspiration, after that wound closes immediately and air cannot escape out, it's closed. Closed pneumothorax. If after the injury, if this big area is injured in the chest wall and air is during inspiration, expiration, it is able to move as it wants, inspiration in and expiration out, then it is open pneumothorax. But if oblique wound is there and flap is in such a way, during inspiration air goes and during expiration it cannot out, this will be tension pneumothorax.
In transbronchial biopsy, tension pneumothorax can occur?
Yes, in transbronchial biopsy, tension pneumothorax can occur, but more commonly other types of pneumothorax. Remember, any kind of pneumothorax can convert into tension, but probabilities are different. For example, if bleb rupture, chances of tension pneumothorax are extremely low, right? But if there is, let's suppose, positive pressure ventilation and patient develop pneumothorax, chances are that it may be tension pneumothorax. You need to act fast, right? So these are the basic concepts about the pathophysiology related with the pneumothorax. Class dismissed. Thank you.